And now I'd like to introduce Dr. Frank Cerra. There are many remarkable educators and professionals in the field of healthcare, but one person stands out for his long history of advocacy and implementation of interprofessional healthcare education and practice. It is an honor to introduce Dr. Frank Cerra, Senior Advisor at the National Center for Interprofessional Education and Practice at the University of Minnesota. We've asked Dr. Cerra to share an overview of how education and practice can create a nexus that will well advance healthcare. Please join me in welcoming Dr. Cerra.
Thank you. Good morning. We're talking about partnerships, and in a lot of the pre-conversations here, I feel I have to say a few words about the Minneapolis-Chicago partnership around weather. My wife and I came back from Portland visiting our daughter and son-in-law, and to arrive Sunday and say, there's going to be a big storm and you may not get out. Well, I've lived in the Midwest a long time, and I said, okay, I'll follow it. So the sun came out, and we took off at 5 o'clock, but lo and behold, guess where the storm went? So there's a reason for that. When the Canadian cold comes into Minnesota, the snow goes south to you. So we have this partnership that's ongoing. You have a glossary of terms here that your staff put together. This is outstanding, and you may want to refer to it as we go through some of this language, because language is an enormous problem when you're talking about interprofessional education and collaborative practice, and we will use these definitions for this discussion. I also ask permission to put this on the National Center's Resource Exchange website, because I think it has a useful function. A couple of words about myself. I actually went to medical school at Northwestern and did a lot of my training at Cook County Hospital when it was 2,500 beds. So I have an understanding of Chicago, and that really led to my career in general surgery, trauma surgery, and critical care. And it was in the intensive care unit that I began to really understand what interprofessional practice could do. So I don't know how many of you ever spend time in an ICU, and I hope as a patient you never do. It's nice if you need it. It does a lot of good stuff. But I soon found out after major trauma or major infections that you do need a doctor who's well trained in critical care and the operative procedures that go with it to stabilize a patient for the first 3 or 4 days. But I then figured out that they called them primary care nurses at that time, nurse practitioner who was in charge of that patient, after about 3 or 4 days could manage that patient better than I could. I also found out that the pharmacist could tell me a lot about drug interactions that I never knew. Well, you know, you kind of got to begin to think about that, so we began to change our format, and a nurse, Joanne Dish, who was head of the Association of Critical Care Nurses, and myself, when I was president of Society of Critical Care Medicine, we formed the first ICU team in the country that was based on the principles of interprofessional education and collaborative practice. And when I left critical care, we had consolidated rounds. The orders were done when we finished. It was an integrated care plan. It involved respiratory therapy, nursing, pharmacy, medicine, and the patient's family. So that was where I began to develop a passion for this field and what it can do. And then I began to understand where the field had come from, and that it basically had existed on the margins of health professional education. And you have one of the greats here. I mean, Dr. Baldwin is the man. He and Hugh Barr and a few of those people did the pioneer work, and they were kind of like John the Baptist for a long time, you know. They just cried in the wilderness, and eventually a bunch of us guys who got into positions where we could use the pens began to say, this has got to go into the core of what we're doing. So when I was Senior Vice President of Minnesota, I hired Barbara Brandt, who, this is her field. She's in there with Bud and Hugh Barr and a few of the rest. And she became the director of the National Center. So I greet you from her, and I'm delighted that you asked me to come and share some knowledge and information as we move ahead on a national perspective for interprofessional collaboration and education. I'm likely to support some of your thoughts, and I suspect there are people in the room that a lot of this will be new, and I hope you get riled up and we have a great conversation, because that's how progress is made. I believe in the true meaning of the word dialogue. You know, you start at a point, you get into a good, as we call it, a Minnesota spirited discussion, and you come out in a different place on the other end. Well, what are we talking about? These standard definitions are the World Health Organization definitions. And there are some operative words here about what IPE is. With, about, and from each other. So, interprofessional education, when the professions learn with, about, and from each other. This is the operative word. This is not parallel play in the sandbox. This is engaging each other and doing what the person needs that you're focused on. This is collaborative practice, and you can read through this. You're focused on common outcomes, and who's at the center? Patients, families, and communities, where they have not been for a long time. So those are the operational definitions. And just to show you an example, this used to be thought of what interprofessional is. This we now call shared loosing, and this is the pharmacists, the nurses, the OTs, and meds. This is not interprofessional learning. This is simply a bunch of people listening to the same conversation. Well, I want to give you a piece of Minnesota history. In 1970, the Board of Regents formed the Academic Health Center at the University of Minnesota. Medicine, nursing, pharmacy, public health, you name it. It was a huge enterprise of all the health professional schools that produced 70% of the practitioners of the state. But in there are some very interesting pieces of the document. And if you read this, right then the students said, hey, we're in this together. Let's learn how to work together. And that set the stage for what we're actually doing. I'll learn how to use this right in a minute. So this is not a new field. And if you go back and read this literature, people have been working in this field for a long time. You also know, and I'll speak to this later, that in the private sector, teams are not new. You know, look at the Toyota model, look at sports, look at the airline industry. But somehow in health, we didn't think that was a good model, so we've kind of ignored it. There's a great deal of interest in interprofessional work right now. The Institute for Health Improvement has changed the game. They defined the triple aim. And this has transformed the country in that the outcomes of health systems are now focused on improving the patient experience, improving the health of populations, and reducing the per capita cost of care. The issue, as we'll see, is these two really aren't where they need to be, and a lot of people are working on this. A lot of stuff saying if it works in industry, why doesn't it work in healthcare? The Quality Patient Safety System Improvement Movement, the Institute for Health Improvement, laid a foundation for outcome-based intervention by teams. The problem with it is it's incremental and it's slow. And the redesign of healthcare is moving very, very fast and must be transformative because the window is short. And if you don't believe that, there are millions of people and health systems now involved with the Center for Medicare Medicaid Innovation, and they will be implementing team models and global fees by 2017 in a huge piece of the population. And it's all based on teams. So that's moving along. The Affordable Care Act is actually doing more of that. Payment and delivery models, the fee-for-service model is in decline. 40% of our contracts in Minnesota are now global fee in one form or another. Competencies are defined, and the accrediting bodies are moving ahead. And you have a group of them present in this room. I'm going to ask them to raise their hands, because you ought to talk with them. They are moving into solving a big problem, and that's as your manufacturing plants turn out providers who understand teams and how to do collaborative practice, the people in the community don't. And if that isn't meshed, the data is very clear. The interprofessional skills that the graduates gain are gone in 3 months if they don't move into an environment. So the retraining, if you will, the change of the environment, the whole continuing education piece is a critical success factor, and this group is taking that on. And the National Center is proud to say we're happy to work with them. And there is an interprofessional continuing education joint accreditation model that you can go to their website or talk with them and learn about. Patients, families, and communities, major movement, largely uncoordinated at this point, but happening. So I'm not going to spend a lot of time on this. You all know the maladies of the current care system. We talked about a lot of these, but the environment today is very rich and fertile for interprofessional education and collaborative practice connected to outcomes. So out of this redesign of healthcare, there was a national movement to say we need a national coordinating center that serves several functions. HRSA ended up funding it, but it's also funded by Macy, the Moore Foundation in California, and Robert Wood Johnson. And it's a coordinating center to provide leadership, scholarship, evidence, coordination, and national visibility to interprofessional education and collaborative practice, which I will refer to as IPEC, because if I keep saying interprofessional education and collaborative practice, it'll mumble. So this is what the National Center is funded to do and is doing. We believe very strongly that high-functioning teams can improve the experience, outcomes, and cost of healthcare. So everything we do is linked to triple aim improvement, whether it's in education or health. So we're advancing the way people work together and learn together to create education, collaborative practice, learning systems. And that is happening on the ground at the micro level, but we're also now beginning to work at the meso and macro level to change policy, and I'll come back to that. And the importance of governance in making change is where we're currently focusing a lot of energy. So, the National Center's goal is to provide leadership, evidence, and resources. And we do this by co-creating and evaluating models of care, this nexus that brings these education and collaborative practice pieces together to focus on improving triple aim outcomes. I used to talk about causally connecting, but there aren't many epidemiologists in the room, and people get nervous when you talk about causation for a variety of reasons. So we now talk about linked to the improvement in outcomes. Strengthening and increasing the evidence and leading and facilitating the national dialogue. Now, one of the things you'll hear me say, there is very little evidence that interprofessional teams linked to improving health outcomes actually do that. There is evidence at the top of the primary care pyramid for complex patients, and that's about the only place it exists. And it's kind of, as we would say, menza menza. It's okay, but it's not great. So as we move along, you'll hear me say, we need to do that, and we need to use this model called the Nexus. So the Nexus is the integration of clinical practice and education in new ways that engage patients, families, and communities and focus on improving population health, reducing the per capita cost of care, and engaging people in the design of the process of care and in their care plan itself. That's what this is really about. And in order to get longevity, we must include students and residents in meaningful ways. The old model of observing is got to go away. I'm not saying observing isn't important and reflection isn't important, but the delivery of health care is a doing profession. And you must learn how to learn for the rest of your life from the people you work with, or you miss the boat. And the best clinicians are those that learn how to listen, learn the language, learn about the cultures, and work with their colleagues to provide the care plan. Leadership is critical, and right now there's a very small group of leaders, and they're well sought after, and one of our jobs is to create a training program for leaders in this field. So who are the partners? Who is the National Center? The actual core group's about 7 people. So where is the movement? Well, it's patients, families, and communities. It's learning organizations. It's healthcare organizations. It's government partners. It's professional organizations. It's policymakers. It's thought leaders. We are the National Center, all of us in this room. And I would say to you, it's our duty and obligation to pursue this pathway to its conclusions in transforming the care delivery system. So here's kind of the model we use that Barbara developed a long time ago, and it's based on others. This is the team steps, if you will. This is not Team Steps, the tool. It's just steps around teams. Most people are here. Well, who are you? Oh, I'm a doctor. Who are you? Oh, I'm a nurse. Well, what do you do? It's parallel play in the sandbox. That's where most people are. The patient safety movement moved a lot of people up because it's a team-based model for continuous improvement. But what you find is if you actually get into the training and education and experience of teams, you can move them up to consider access, workforce, community health, driving costs out of the system, and improved health and learning outcomes. And that's the model that the National Center uses to help people and assist people. A lot of trends shaping what we're doing, and I'm not going to spend a lot of time on this, but some of these I think are important. There's not a lot of standardization and approaches to teams. Nobody really knows how to train one of these teams. Nobody really knows how to evaluate the functionality of a team. What are the knowledge, skills, and attitudes, and how do you actually evaluate them and improve them and keep them focused on outcomes? That's a problem. What do they mean for workforce needs? You know, if you begin to think about this, and you get social work, occupational therapy, physical therapy, speech therapy, so on and so forth, they all have meaningful roles at the right time and the right place to take care of the right kind of people. And I'll show you some of these new models that are going on. There are not a lot of good models to deal with, and it's going on in education as well as in the private sectors. There's a lot of experimentation going on, but it's disconnected. And so you got education doing this over here, and the ones that have hospitals and clinics inside their system, they're doing one thing. The other health systems don't, and mind you, less than 4% of the care that's actually delivered in hospitals and clinics happens in academic health centers and medical centers. 95% of it is out in the community. They're experimenting from this, trying to figure out how do you actually do it, and they're not sharing information. Here's something that's falling out. We probably do not have a healthcare workforce shortage. We have a lot of maldistribution. We have a lot of ego in getting advanced practice nurses and clinical pharmacists and doctors to figure out where there's spheres of care that they can overlap and do independently. And there's the University of North Carolina, Chapel Hill has put together in their economics department models that use advanced practice nurse clinics and primary care clinics, doctor-led. And when you begin to figure that into the equations for workforce, you don't come up with a lot of shortage of the actual core providers. Where you come up with shortages is rural areas, and I should say, I guess I should mention one other, areas that are underserved but non-rural. So one of the areas we have a great interest we're working with, and I'll show you a little bit later on, is St. Vincent de Paul's Father Joe's clinics in San Diego, big homeless clinics, and they have a model that's absolutely startling in its success rate. So we're doing some ethnographic work, and we're including them in what we're doing. So we're training people in the Flexner model that's 80 years old. And it's not just medicine. Every health profession has adopted the Flexner model in one way or another. So whether you've talked to nurses, they have one model, doctors have a model, and the pharmacists have a model, and they're all captain of the ship, and it all has to move in a different direction. So what happens when you begin to get people together? These are what we've called courageous conversations. We've gone around the country and had these in about 50 different sites where we pull together all the stakeholders. We talk about this. And there's growing recognition that there needs to be a reconnection of education and practice at all levels. We need to provide credible evidence that this model improves outcome. We need to support the development of leaders and advocates. And you'll hear me talking about the people with the pens. There are a group of those at the macro, meso, and micro level that can change the world. We just need to convince them to do it. That's kind of the top down, and it has to come from the swell of the bottom up. And we need to do our job in improving training and clinical experiences, not just in the schools, but for lifelong learning. I had to teach my daughter about this. She's an advanced practice nurse, just graduated, and she's setting up some APN clinics for the University of Pittsburgh Medical Center. And she was all fussing about it. I said, look, what you came out of in your training is just the beginning. You have to learn how to learn for the rest of your life, from the people you work with, from your patients, from your mistakes. You can't be afraid to make mistakes, but you've got to learn from them and move on. And keep your eye on the brass ring, which is the health of that person or the health of that population. If you keep your eye on the brass ring, you'll get where you want to go. These are the competencies of the Interprofessional Education Consortium, and they are important and need to be taught, but they are limited. This is what's already been defined as additional competencies. Population health, patient-centered decision-making, evidence-based decision-making, cost-effective practice, quality improvement, stewardship, systems thinking, and informatics. People always ask me, what's informatics? Here's a simple way to think about informatics. It's getting the right information to the right people at the right time to make the best decision, and then letting them know how that decision worked. That's what informatics is about. And the rest of it is the math and the databases and the systems. But unless the people we turn out understand this, and it's already happening in Minnesota, where almost 75% of the docs, for instance, are employees, they don't know how to act as employees. They don't know how to use this information on an integrated service line. And they have to be taught that. So here's what the National Center does. It informs, connects, engages, and advances. We don't tell anybody how to do anything. We observe. We observe, we take in, we provide evidence, we provide information, we provide access to the world's data in this area, and then we raise Cain. We inform the people with the pens, we form coalitions, and people begin to figure out that participating in our partnership network makes a small voice a national, loud, potent voice. And that's where we're trying to get. And if you go talk to the stakeholders, walk into a C-suite, the first thing the CEO says, what's the return on my investment? Well, we're going to show them that, and I'll show you how we're going to do that. So here's what we do. We have an incubator network and a National Center data repository, and I'll speak about a little bit about each one of these. We have a resource exchange, we develop tools and training, and we're driving national change. I can't use the word advocacy around HRSA because it's a violation of the federal rule, so we talk about educating, informing, and linking up the dots. And we kind of get to the same point. This is our current national network, and it grows by the day. So each of these sites has an interprofessional team, a Nexus, linked to improving one or more triple aim education and health outcomes. And we work with those sites, so they're scientifically sound in what they're doing. We don't bring any money. We're not a funding agency. We're an observer collection assisting agency. But we do help them get grants. We have a 95+% success rate when somebody wants to work with us on a project intervention in getting them local funding or national funding, depending on what it is, including insurance companies. We have a good success rate in doing that. So these are across the country. These look like they're university centers, and in a sense they are. They're the manufacturing plants, but they're all on the health system side, because that's where the end outcome is, and they all feed back into the education system. So what does an incubator look like? They integrate clinical practice and education. They have an intervention that has impact on the triple aim. They involve students and residents. We know that if you follow the usual formative, summative, randomized controlled trial in this setting, you will fail. That model does not work. Why? It's a business kind of model where you focus on the outcomes you want to achieve and you manage over time to the outcomes. And you know as well as I do, the best laid intentions of mice and men don't happen. And you're always changing direction. You're adding to the team, subtracting to the team. Somebody in the C-suite says, nuts, I'm not going to fund this. The funding organizations change. The funding models change. So we spend a lot of time also understanding the ecological environment within which the intervention is occurring. So we will eventually be able to say, by aggregating this data in a centralized database, this intervention with this team improved these outcomes in this ecological environment, and it resulted in sustainable change, and we're going to transport it to a different environment and try it out again. That's where the National Center is. So we have to have data sharing agreements, and we've worked about all of this intellectual property and all of that kind of stuff. If you're interested, I can talk to you more about that. It's very straightforward. It's easy to do. We actually have 22 projects now up running, so some of these numbers I'm going to show you are not correct. And we're onboarding 20 to 30 sites a week for a year for the next 2 to 3 years. So I hope this generates some interest and we can get a project going here, or 2 or 3 projects, because we need you. We need the city of Chicago. Here's the kind of things we look at. Demographics, what's going on in education, how do you train your teams, what do they learn, what don't they learn, what are your cost inputs, what are your user surveys, and then what is the site-specific project, we call it, which is the actual data you collect for your intervention. We're not interested in identified data. We're only interested in aggregated data, which solves a lot of problems for you. And all of our central repositories are de-identified aggregated data. So that's the kind of data we collect. This is what needs to be shown. The extent to which interprofessional education and collaborative practice can improve our health outcomes, education outcomes, identify the ecological success factors, identify the changes needed in policy, accreditation, credentialing, and licensing, and establishing a causal connection, a linked connection between the educational model, the practice model, and the outcomes. And we're using a return on investment data model that allows us to do that. It was actually, the initial development was by the Canadian governance systems. We then adapted it and adopted it to the United States health system, and we're filling it up. So this is some of what's going on. People are looking at electronic health records. Most people don't really like electronic health records. There's a reason for that, and there's a very innovative project going on in the medical ICU. This is probably one of our few inpatients, where what they did is they looked at medicine, nursing, pharmacy, respiratory therapy, and the other professions, and how they viewed information on the electronic health record screen, and found there was a 44% error rate in the care of the patients because of the way the data was displayed. So they used these models and developed some simulation and are now taking it back to the medical ICU, looking at screen displays to promote interprofessional, integrated critical care. People are now looking at the back end and saying, what can we get out that's useful? And of course, most of the electronic health record companies aren't real interested in that. I don't know why, but we're making headway in that because the informatics people understand what's in that box and how to get access to it. So we're looking at new roles. For instance, I'll give you another example. There's in Pittsburgh, the acute trauma unit discharges their patients to the trauma rehabilitation unit, which is run by what they call an advanced practice provider. It's either an advanced practice nurse or a physician assistant. And they take care of those patients. They call the doctors if they need them. And it works. So it's a different model of care. Care transitions are a big deal, and we have 4 sites looking at these, and if you look at care transitions, it's the biggest place for errors there is. The handshakes don't work. They don't form good teams. If you look at the care plans, each profession listed, so there's no integrated care model. The drug error rate in the transfer to a new system exceeds 50%, so on and so forth. So trying to figure out how do you work that is a key piece. A lot of chronic care conditions. I'll give you one example of this in an FQHC clinic network in Western Michigan. Because of the Affordable Care Act, this particular network was getting 6,000 new Medicaid patients. They were using the old doctor-centric model. It's going to work. They're intervening with a team model, doctors, nurses, pharmacists, and students with meaningful roles. The schools in Western Michigan designed a curriculum and a training program. It is now being implemented. They're looking at diabetes in particular, but also clinic productivity, and it's happening in a state where the SIM grant is looking at payment systems to support that. So that's the Center for Medicare and Medicaid Innovation. Primary care, there are 2 models being looked at here nationally. One is an advanced practice nurse-centric model, the other is a physician-centric model with an expanded role for a medical assistant. We're collecting data on all of these, some in primary care clinics, FQHC clinic networks, and trying to figure out, are they comparable, uncomparable, where do they work, where don't they work, and so on and so forth. So, ecological factors. I know my time's a little up, but I'm going to run over because my dad, who is a professor of English, said, if you got the podium, use it. So I'm going to be about 5 minutes. I'll just let you know that. And I found out he was correct, and it serves you well if you heed that advice. Many of you who have been involved in change are not going to be surprised by the critical success factors. If governance in the C-suite isn't on board, there's no sustainable change. It does not happen. And one of the poorest, I'm going to say this, I hope it doesn't offend everybody, I've spent almost 40 years in not-for-profit health governance on boards. One of the groups that has the poorest understanding of healthcare and the reformation that's occurring resides on governing boards. And I don't like blame as anything, but I'll tell you, a big part of the problem is the chief executive officers, because it's not part of their training program. Whether it's health administration or business administration, I teach horizontal integration for health systems in our health administration and MBA program, and it surprises me when you begin to talk about teams, the paucity of knowledge. It's not the CEO's problem per se, it's the education system's problem and the continuing education system's problem. We have not included them and dealt with them well, along with a lot of other people. So if you look at this list, and these slides are public, I'll leave them here. You can do as you wish with them, study them, I hope. And that's the kind of thing we do. And the National Center does a lot of things. It's surprising how little is understood about this method of collecting evidence, data to produce evidence. This longitudinal collection of data over 2 or 3, 4 years where you understand here's a critical incident that changed how they approach getting to this outcome. This model and its scientific integrity so that you can produce statistically relevant data and on the qualitative side, meaningful data, needs an education process. And we work with centers to understand how that works, how to set up their databases, how to integrate their data, And that's the kind of resources that we bring to the table. We also end up in C-suites, talking about return on investment and those kinds of things, and so on and so forth. Okay, this is the resource exchange. You can all go on the website and get this. This is the world's compilation of relevant literature in IPE-CP, and it keeps growing. All of the validated instruments for assessing team function are there, as well as their constraints, because none of them are really designed to look at teamness and team function. And we're developing a way to either improve those that exist or develop some new ones, because it gives you information that you need to know. I'll give you an experience of a CEO at an FQHC clinic network in Portland that I spent an afternoon with, and here are his questions. He says, I don't know who needs to be on this team. How many times a week do they need to meet as a team? I know we've got 5 major diseases in our population area. Should I be focusing on a team, on a disease? How do I engage my communities? And that's what they're looking to get some guidance in. What are other people doing? What are success stories? What's working, what's not working? And believe me, there are a lot of success stories, and they happen at many, many, many levels. You're aware of the asthma stuff that the CDC is doing and how they're working with public health and primary care, and it's quite amazing what output they have. So this is what we do to inform national change. We put data out there, we put information out there, we collaborate, we form coalitions, we begin to work with the people with the pens, because that's where it has to happen, whether it's bottom up or top down. You can kind of read this. This is the kind of thing, I've talked a lot about this. We actually now have enough data in the National Center Data Repository. We're producing a 2.5-year report of what we've learned. So you'll begin to see this in the next 3 or 4 months. There's a publication out there in a journal called Healthcare that's all about this incubator NCDR network and the model of data collection. Our research agenda paper is going into press in the Interprofessional Practice journal. So we're beginning to get this out there, and here's what we think it's going to look like. High performance teams. You'll know where they work, you'll know where they don't work. There has to be a whole new relationship between education and collaborative practice. I've talked about this as the knowledge connection, the experiential connection. But if you begin to think that through, you'll begin to understand it goes beyond that. The health systems and the educational institutions are going to have to give up some things to work together. They're going to have to financially support each other. They're going to have different ways of decision-making and governance if this model is to succeed in the transformation of healthcare. That's well described in a section of the Macy report on interprofessional practice in education from 2013. I know it's good because I wrote that section. The payment models, this is a big deal, and it's happening. But how does the global payment system in its various forms, whether it's per member per month or a real global fee or so on and so forth, how does that actually support teams in an environment where the teams are employees and they have to get used to understanding performance criteria, so on and so forth. We also think the National Center will need to be around for a while to help this process move along. So I apologize for running over, but I thought it was a great message. And thank you very much. All we've got a few minutes for Q&A. Fire away. Yes?
Yes, as you know, the SGR discussions are once again going on. And, oh, thank you. The SGR discussions are going on.
Does everybody know SGR?
Sustainable growth rate. Okay.
Did I hear you?
Sustainable growth rate, the Medicare payments to physicians. I think, once again, we're looking at the payment model without really changing practice. So I don't see anything, I have never seen anything coming out of these discussions that say what we really need is a team-based model of care, and that would affect the payments to physicians. So I'm all about paying physicians a lot more money. And I think
you're just saying that.
No, I mean it. I think they'd appreciate it, but only for the things that physicians can do. So that if we begin to sort out practiced and team-based care, maybe we'd come up with a model that physicians would actually feel comfortable about.
I couldn't agree with you more. And I think more and more docs are coming on board, particularly in primary care, looking at different models of care. But I would say this in some defense of the Center for Medicare and Medicaid. CMMI's latest FOA says, here are the outcomes we've established. Here's what you must perform on. Here's a lot about how your team must deliver the goods. And in 2017, you will be paid a global fee for that. Now, they're hedging in the sense of how does that money get distributed? And of course, the great unknown is, let's say you drop the cost of care 40%. Who gets the money? Undecided. But a lot of people interested. And hopefully some of it shows up in the premium reductions. That's my hope, but I don't know. So I think you're right. And I think this process of the road we're on now can get to that, but it's a bottom-up, top-down process. It's a lot of work. It's a major commitment. You walk around with targets on your back. You get used to it, and that's what has to happen. But the National Center, as I said, these 8 people sitting up there at the University of Minnesota cannot do this. We need the whole network, and we need you to be part of it. There are many ways of doing it, and we need the city of Chicago's weight behind it. You carry a lot of weight in the national politic. I think you know that because I've seen you use it, and it's a good thing. I like the system we have, but I think we'll get there. It's not going to be easy. But it's got to happen in the next 3 to 5 years or we lose the window. That's all I can say. That's why, Barbara spends most of her time on the road. I'm kind of the backroom guy getting this thing to run because that's what I do, and come out and talk to people like you who I think are receptive to this. Another one? You can also make a comment that I turned into a question. That's okay. Yes?
Hello. Thanks for a great presentation. What I'm curious about is how do you overcome the institutional silos of health information technology, and specifically as you develop new interdisciplinary team-based pathways, how do you actually have them spread to the network that you're describing when there's so many other stakeholders informing that HIT development?
There's an old expression that I use a lot about change, and there probably is not a book on change that I haven't read or talked to the sociologist on. But ultimately, change happens one person at a time, eyeball to eyeball. Period. I don't care what level it's at. It's that personal interaction. It's that personal confidence that it isn't just having data. In some cases, in my own experience, if I'm telling them the data, they'll believe it and use it. If Dr. Joe is telling them, they won't, because they know me. They know my credibility. They know I'm not going to tell them something that I don't really believe in. They know my values. They know my ethics. And that is the great change maker. I don't care if it's in governance, the C-suite, in the clinic. That's what has to happen, and you need people with the education and training to do that. And that is the major role, in my opinion, of our manufacturing plants, whether it's in the initial phase or the continuing education phase, to provide that knowledge and that learning and impart that leadership strength, which is what it takes, because you do take a lot of crap along the way, to get this job done. And I think if you find the history of change, that's really how it happened. A lot of help from people with the pens? Yeah. When the people with the pens are convinced, they can make a lot of things happen. When I was senior vice president, the informatics people didn't dare to not work together because they knew I wouldn't give them their funding. All right? I had that kind of control in the university. Those are useful tools, but only for a certain amount of time in the right environment. That's why the payment system tool is a great tool, but it's not going to do sustainable, transformative change on the line, which is where it needs to happen. That's my answer to your question. It's work and it's commitment, and you got to want to do it. One more? Yes.
Thanks very much. I'm Kate Renier. I'm one of the 3 accreditors in the CE space, along with pharmacy, doing the joint accreditation. And one of the things that this is a bit of a statement for you to react to. One of the things that we're learning is that it goes beyond healthcare. And I think what you can learn, what we all can learn, for example, from our colleagues from the Chicago Public Schools, is how to connect with the community, how to connect with the patients. And the impact beyond healthcare to the health of the patients is what we're seeing is a big challenge, and one that can really be improved by this approach to interprofessional education and interprofessional collaborative practice.
I think it's well said. I'm going to stretch it a little bit. Frequently what happens, and I want to say it a different way, we generally start from the point of view of the hospital and clinic, and the patients come to it. That model must change. Health must go to the patient and the community and in the environment they live, or we're not going to redesign healthcare. So, I'll use my daughter again as an example. As she's setting up these APN clinics, she sees patients in the clinics with her primary care docs and the pharmacist, and she follows up those patients into the home and provides care in the home. They stay in the home. They stay out of the hospital. They generally don't need to go back to the clinic. And if there's a piece that's not working, for instance, in an asthma patient, a kid who's living in a house with lots of dust and nobody wants to pay for a HEPA filter, there's a team of lawyers that we work with that deal with that, and they'll get a HEPA filter for that person. You need the community health workers. My son's a landscape architect. He's a professor at Cornell. So he's teaching me how to design communities to support health. It isn't expensive. It's taking the existing resources and thinking about how to use them better. So what do you do with the community centers? How do you better engage with your public health systems and bring it to the community in a different way? And I think you're going to hear about some of that innovation from the next speaker. This is a critical success factor, and incidentally, one of our funders. Do you know the Moore Foundation, Intel, Mr. Intel? He's still alive, he and his wife. His wife had a bad experience in a critical care unit with coordination of care, so she's funding a lot of projects on that, but the Moore Foundation is very interested in this community connection. And the Macy report that came out in 2014 is all about engaging communities. And I'm going to go to your session on engaging communities because there's a whole lot to learn there that I don't know. And one of our challenges is how do we bring communities into this national database network and learn from it. And the last thing I'll say is if you go to the National Center's website, you'll see a video there called Amina. And it's all about a Somali diabetic in an inner city community who learns the value of interprofessional team care delivered in her community and connected by these. This is a game changer. People saying, well, inner city people can't do that. Ain't true. These have been tested for diabetes care in Native American inner city communities, and it works very well, and the theft rate is less than 1%. So it's a matter of, I think, rethinking our current assets and approaches and finding ways to use them differently and more effectively. That's my stretch on your comment. Thank you.